four types of fat soluble vitamins A, D, E and K, and in this video we are going to see vitamin D. There are two main types. One is cholecalciferol, which is of animal origin, and second is ergocalciferol, which is of plant origin. Cholecalciferol has a precursor called 7-dehydrocholesterol, from which cholecalciferol is produced, and the precursor of ergocalciferol is called ergosterol. 7-dehydrocholesterol is present in the epidermis of the skin, and when UVB rays are falling on the skin, there are three types of UV rays, A, B and UVC. Specifically, when UVB rays are falling on the skin, 7-dehydrocholesterol is converted to pre-vitamin D3, which is further converted to cholecalciferol. But this is still not in the active form. From the blood, it has to go to the liver. So it has to undergo two hydroxylation reactions in order to get converted to the active form. First reaction takes place in the liver. By the enzyme 25-hydroxylase, cholecalciferol is converted to 25-hydroxycholecalciferol or hydroxy D3, and this is also known as calcidiol. Then it goes to the kidneys, where the second hydroxylation reaction takes place. By the enzyme 1-alpha-hydroxylase, this gets converted to 1,25-dihydroxy D3 or cholecalciferol. This is also known as calcitriol. And finally, this is the active metabolite. This is also known as a hormone because this is the form that brings out the physiological functions of vitamin D. So we will understand why this is called as a hormone when we get to see the functions of vitamin D. 25-hydroxycholecalciferol is the storage form, major storage form, and it is also the main circulating form in the blood. So when we are doing a blood test to check the amount of vitamin D that is present in the blood, 25-OHD3 is the form that we are looking for, not the active form, because this is the form that is mainly circulating in the blood. This form 125 calcitriol has a shorter half-life, and the amount of calcitriol present in the blood is being tightly regulated by parathyroid hormone and levels of calcium and phosphorus in the blood. So if we test this, it's not really a reliable measure of the amount of vitamin D. That is why calcidiol is the form that we are testing in our blood. We get vitamin D from two main sources. One is from sunlight exposure, and second is from diet or supplements. So supposing a fish is being consumed or eggs being consumed, first in the intestines, in the small intestines, say let's take fish or eggs, in the jejunum of the small intestine, animal origin is cholecalciferol, right? So cholecalciferol from the dietary sources, with the aid of bile salts, it is incorporated into the chylomicrons, which travel through the lymph and eventually into the bloodstream, and from the bloodstream it goes to the liver and then to the kidneys to be converted to the active form. Same goes for plant-based. Supposing mushrooms are being consumed, it has ergocalciferol. So it goes through the same cycles. From the intestine it gets absorbed, liver, kidneys to get converted to the active form. Calcitriol has two main functions. Calcium homeostasis, it regulates the amount of calcium in the blood, and second is bone remodeling and mineralization. But it doesn't do these two activities by itself. It works alongside parathyroid hormone. The main function of parathyroid hormone is to regulate calcium levels in the blood. So when there is a dip in calcium levels, it stimulates the parathyroid gland, which secretes parathyroid hormone. This goes to the kidneys and triggers the conversion of 25-OHD3 to the active form calcitriol. Now calcitriol has been generated. It has to regulate the levels of calcium in the blood. Calcitriol and PTH do this by three steps. First, calcitriol acts on the intestines increases the CBP, calcium binding protein called calbindin, and increases absorption of calcium and phosphorus. So this is one way of increasing calcium and phosphorus levels in the blood. Second, PTH and calcitriol act on the kidneys and increase the reabsorption of calcium, thus preventing excessive calcium from being excreted out in the body. So that is another way of increasing calcium and phosphorus in the blood. Third, PTH and calcitriol act on the bones and stimulate osteoclast or bone resorption cells activity. So they increase the mobilization of calcium and phosphorus from the bones into the blood. So now they have brought about an increase in the levels of calcium in the blood. Now what happens is calcitriol inhibits parathyroid hormone, further secretion of PTH. So this is the negative feedback loop that goes on. Once the levels of calcium is regulated, calcitriol inhibits parathyroid hormone so that there is a balance in the amount of calcium and the amount of parathyroid hormone and calcitriol. Second, calcitriol is involved in bone remodeling and mineralization. Remodeling means both resorption, both osteoclast activity and osteoblast activity. Though D stimulates the mobilization of calcium and phosphorus from the bones, they are bringing about a balance in the levels of calcium and phosphorus in the blood. So once the levels of these in the blood come to the normal range, it automatically stimulates the mineralization of bones, depositing the calcium and phosphorus into the bones. The RDA for vitamin D in adolescents and adults is 600 international units or 15 micrograms, and in adults above 70 years of age, it is 800 international units or 20 micrograms. As we age, the efficiency of synthesis of vitamin D from sunlight exposure decreases. So the requirement also increases above 70 years of age. 1 microgram vitamin D is equal to 40 international units. And the sources, dietary sources include eggs. Roughly a 50 grams egg or a single egg can give about 40 to 45 international units of vitamin D. Fish, fatty fish, fish liver oil are all good sources of vitamin D, and UV treated mushrooms. Generally mushrooms are a good source of ergocalciferol, but when it is treated with UV light, the quantity or the amount of vitamin D significantly increases. In the blood levels, when a blood test is being done, 30 ng per ml, nanograms per milliliter to 50 can be considered to be in the optimum range. Anything below 20 is considered as deficient, and levels below 10 is severe deficiency. Levels above 150 ng per ml can be called toxicity. Anything above 70 to 150 is very high, and above 150 is considered toxicity. This can lead to hypercalcemia because vitamin D increases calcium absorption. So too much vitamin D can lead to too much calcium levels in the blood. Deficiency of vitamin D could be caused by a number of factors. First, could be limited sunlight exposure due to various reasons. For example, dark skinned people, they synthesize vitamin D at a much slower rate compared to fair skinned people, because dark skinned people have more melanin, and the melanin competes with the UV rays and it absorbs the UV rays, thus reducing the amount of UV rays that reaches the epidermis or the 7-dehydrocholesterol. And use of sunscreens also impacts the synthesis of vitamin D from sunlight exposure negatively. That doesn't mean one has to go out without sunscreens, it's just one of the limiting factors. And UV rays cannot penetrate through windows. So though sunlight might come inside the room, it does not help in the synthesis of vitamin D. Chronic kidney disease, because the second hydroxylation reaction where calcidiol is converted to the active form calcitriol, that takes place in the kidneys. So if there are renal issues, that could lead to vitamin D deficiency. Chronic liver disease like cirrhosis or any liver based disorder can lead to vitamin D deficiency because the first hydroxylation reaction takes place in the liver. Gastrointestinal disorders, malabsorption syndrome or celiac or pancreatic insufficiency, any GI related disorder where the absorption is affected can lead to vitamin D deficiency. Last could be a reduction in the dietary intake of vitamin D. But this is not a very important contributor because only 10 to 20% of vitamin D is obtained from the diet. Rest is through supplements or sunlight exposure, but this is one of the important contributing factors for D deficiency. Once someone becomes deficient, the two main vitamin D deficiency disorders are rickets in children and osteomalacia in adults. Rickets is the softening and weakening of the bones in children, and it is the most severe in children between the ages of 1 and 3 years. The earliest sign is craniotapes, which is the thinning and wasting of the cranial bones. So when pressure is applied on the child's skull, it can slightly indent like a ping pong ball, and then it can pop back to its normal structure. All these are because of reduced mineralization of the bone due to vitamin D deficiency. Delayed closure of the anterior fontanelle. This usually closes by 2 years of age, but in case of rickets, the fontanelle that is on the top of the child's head, there is a delayed closure of it. Frontal and parietal bossing. This could lead to a significant protrusion of the forehead part. Pectus carinatum or pigeon chest is an undue prominence of the sternum, so there is a protrusion of the chest area as well. Rachitic rosary. There is an extension or widening of the epiphysis at the wrist, radius, ulna, or at the costochondral junctions of the ribs. So bead-like appearance or rosary-like appearance is found in the ribs. This is called as rachitic rosary. If all these symptoms are untreated and left to continue into the second and third years of the child's life, the child will start to sit up, it will start to crawl. So there is a new gravitational and muscular strain that is being added. This can lead to kyphosis of the spine, which can later progress to lordosis of the spine and other skeletal deformities. As the child starts to walk, knock knees or genu valgum. So the knees are knocked like this, or it can be bowed, slight bow like this due to deformities in the shaft of the leg bones. Osteomalacia and rickets are almost the same, where there is a defective mineralization of the bones because of a vitamin D deficiency. The only difference is this takes place after the growth plate or the physis have been closed. That is why osteomalacia in adults and rickets in children, because in children the physis is not yet closed. There is bone pain and muscle weakness that is present in osteomalacia. And rarefaction of bones. This can be diagnosed by a number of ways. When an X-ray is being done, there can be thin transverse lines that are present on the bones. These are called as loser's zones, but this is not the only diagnostic criteria, because this can also be present in other bone related conditions. Blood tests that test the amount of alkaline phosphatase, parathyroid hormones, D and calcium. So a number of diagnostic criteria is there to diagnose this condition. The main difference between osteoporosis and osteomalacia is that in osteoporosis, the rate at which bone resorption or bone breakdown that takes place is higher when compared to the bone formation. So the total amount of bone mass is decreased, the total amount of bones in the body is decreased, thus putting the person at a higher risk of fractures. In the case of osteomalacia, bone mass is the same, the amount of bones is the same, but it is not properly mineralized. Because of a lack of mineralization, the bones are not hardening properly. The amount of calcium and phosphorus in the bones is less. So there is more of soft osteoid tissue that is present, making the bones soft and bended. I hope vitamin D and its functions, RDA deficiency disorders are clear. Any feedback, feel free to drop it in the comments below.